In vitro fertilization, or IVF, is recommended for women with tubal blockage, endometriosis, unexplained infertility, and ovulation problems. It is also recommended for male factor infertility. In vitro fertilization is a procedure which involves the stimulation and removal of eggs from a woman's ovaries. They are fertilized with sperm in a lab, and then the fertilized egg or embryo is returned to the woman's uterus in a process known as embryo transfer. There are generally 6 phases to an IVF cycle. We'll detail each of those here. During an IVF cycle, it is desirable to have several eggs mature simultaneously. At the same time, we need to suppress the pituitary gland, which is responsible for ovulation, because it's important that you do not ovulate until we are ready to retrieve your eggs. To accomplish this, we use medication that prevent the surge of the hormone LH. Next is a process called super-ovulation, involving medications containing gonadotropins. Gonadotropins, such as FSH and LH, are used to stimulate egg growth and development. Their purpose is to grow numerous mature follicles, rather than the single follicle that is usually produced each month. Your response to these medications will be monitored using a combination of vaginal ultrasounds to measure follicular growth and blood tests that measure the hormone estradiol. Eggs develop within follicles which contain fluid and can be seen by ultrasound. The actual egg is microscopic and cannot be seen by the human eye. During the process of ovulation induction, follicles grow in size as the eggs mature. When the follicles are large enough, usually after 10 to 12 days, the stimulation phase is completed with an injection of HCG. This hormone is given 36 hours before your egg retrieval to trigger the final maturation of the eggs. Fertility medications have temporary side effects that will resolve shortly after stopping them. You may experience hot flashes, nausea, breast tenderness, headaches, mood swings, lower abdominal heaviness or discomfort, bloating, tiredness, slight forgetfulness, and changes in your menstrual cycle. The procedure is usually done under conscious sedation, meaning you will be awake but comfortable. You may also be given a local anesthetic in the top of the vagina and intravenous medications for relaxation. The egg retrieval is performed by an ultrasound-guided needle puncture through the top of the vagina into the ovary. The needle is passed into each follicle and fluid is aspirated into a test tube. The fluid from each follicle is examined under a microscope. Not every follicle contains an egg. The procedure itself will only take 10 to 15 minutes, but you will be asked to rest for about 1 hour afterwards, as it is common to experience some cramping and discomfort after egg retrieval, as well as some vaginal spotting or bleeding. Your doctor will discuss the use of pain relief with you before you go home. The hormone progesterone will be prescribed to help keep the lining of the uterus in optimal condition for implantation. You are often encouraged to rest for a few days after the procedure. The male partner will need to produce a semen sample that day, or if using frozen sperm, the sample will be thawed. To optimize the sperm count, it is recommended that men follow these guidelines for at least 3 months before treatment begins. Minimize the use of alcohol and cigarettes, and avoid using marijuana. Avoid hot tubs, saunas, or anything else that will overheat the scrotum. Report any fevers or illnesses to the clinic, as this may affect your sperm count. Sperm are produced constantly. To obtain the best sample on the day of the egg retrieval, we suggest having intercourse or an ejaculation every 2 to 5 days. If you have not ejaculated for more than 5 days, the sample may have many dead sperm. If you are more comfortable bringing a sample from home, we ask that you deliver the sample in an identified container within 30 minutes of producing it, and keep it at body temperature. If you have difficulty producing a sample by masturbation, freezing a backup sample is a possibility. This may reduce the anxiety of producing one on the day of the egg retrieval. Please discuss this with a member of your healthcare team. Once the test tubes of follicular fluid are received in the laboratory, the embryologist examines the fluid to find the eggs and grades them for maturity. The dish with the eggs is then safely stored in an incubator until it is time to add the sperm. The embryologist prepares the sperm using a washing technique that concentrates the sperm cells and removes seminal plasma and white cells. Identification of your eggs and sperm is maintained throughout all these processes. A few hours after the egg retrieval, approximately 500,000 moving sperm are added to the eggs. Fertilization takes place by the sperm penetrating the outer layer of the egg. This should happen over the next several hours when the dish is securely kept in the incubator. Intracytoplasmic sperm injection, or ICSI, is a procedure in which a single sperm is injected directly into the middle of an egg. This procedure is most commonly used to overcome male infertility problems, although it may also be used when eggs cannot easily be penetrated by sperm. ICSI is a very effective method to achieve fertilization of eggs in the IVF lab after they have been retrieved from the female partner. IVF with ICSI involves the use of specialized micromanipulation tools and equipment and inverted microscopes that enable embryologists to select and then pick up individual sperm in a tiny, specially designed hollow ICSI needle. Then the needle is carefully advanced through the outer shell of the egg and egg membrane, and the individual sperm is then injected into the inner part of the egg. This will usually result in normal fertilization in approximately 70 to 85% of eggs injected with viable sperm. ICSI is considered a safe and effective therapy for male factor infertility, but may carry an increased risk for the transmission of selected genetic abnormalities to offspring, either through the procedure itself or through the increased inherent risk of such abnormalities in parents undergoing the procedure. It is important to discuss this option in detail with your doctor. The next morning, the eggs are examined under a microscope to determine whether or not fertilization has occurred. If the eggs are fertilized, we see two pronuclei, one from the egg and one from the sperm. This carries the genetic information from the egg and sperm. 2 days after the egg retrieval, the fertilized eggs are examined for cell division. There should be at least 2 cells at this point, and there are often as many as 4 cells. At this stage, they are considered embryos. Luteal day 3 to 5, or 3 to 5 days after the egg retrieval, is the day of the embryo transfer. At this point, the embryos are generally a mix of various cell stages. Embryos which are at least at the 6 to 8 cell stage are considered to be developing appropriately, and these are the embryos that are selected for embryo transfer. Some fertility clinics wait until day 5 to prepare for an embryo transfer. At this point, the embryo will have many cells and is called a blastocyst. Embryos are usually transferred to the uterus 3 to 5 days after egg retrieval. Embryo transfer is not a complicated procedure and is performed without anesthesia. The number of embryos transferred depends on a woman's age, cause of infertility, pregnancy history, and other factors which will be discussed by your doctor. An embryologist will discuss the number and quality of your embryos immediately before the transfer. The embryos for transfer will be loaded into a transfer catheter. The catheter is passed through the cervix into the uterus. The embryos are released and the catheter is slowly removed. Afterwards, the catheter is checked under the microscope to ensure there are no embryos stuck in the catheter. If there are additional embryos, they may be suitable for freezing and used at a later date. Embryos that are not transferred may be frozen if the patient desires and if they are of suitable quality for freezing. The criteria for embryo freezing are quite strict. The embryo must be at least 6 cells and have minimal fragmentation or damage. If the fragmentation is greater than 10%, the embryos tend not to survive the freeze and thaw process. Instead, these embryos are observed in a culture medium for up to 4 more days following embryo transfer, to allow for further development and freezing later. If they do not develop, they are discarded. The embryo freezing procedure is a technique that slowly draws the water out of the embryo and replaces it with a cryoprotectant, a sort of embryo antifreeze. Once the protectant is in place, the embryo is cooled and stored in liquid nitrogen. Embryo thawing is the reverse procedure. The water is slowly transferred back into the embryo and the protectant is washed out. After the transfer procedure, you should rest for a week and avoid being on your feet for long periods, lifting, pulling, pushing, aerobic, strenuous, or bouncing activities. You should also refrain from sexual intercourse for at least 1 week and stay out of hot tubs and saunas. All of this because your ovaries have been stimulated and may be much larger than normal. It's important not to jar them. Also, the puncture sites from the egg retrieval need time to heal and prevent infection. Otherwise, you should be continuing with your progesterone supplements and call your fertility specialist if you experience abdominal pain, increasing abdominal bloating, weight gain, fever, spotting, or bleeding. The luteal phase is the 2-week waiting period between the embryo transfer and the pregnancy test. The embryo must undergo further development until the cells divide to a blastocyst stage. After this, the cells should hatch from their shell before implanting into the endometrium, the uterine lining, to be safely housed within the walls of the uterus. There is very little you can do at this point to affect the chances of successful implantation. Whether or not the embryo or embryos implant in the uterus is primarily dependent on the health of the embryo, and many of the tests at this point can send us mixed signals. While this is very disappointing, it does not always mean the treatment was unsuccessful. Some women experience unexplained bleeding during pregnancy, so if your doctor has prescribed a progesterone supplement, you should continue taking it until the results of the blood tests are confirmed. At the same time, the progesterone may delay your period. This does not necessarily mean you are pregnant. So there can be a fair bit of uncertain waiting at this point. Your best bet is to keep your eye on the ultimate goal and not to get caught up in the uncertainties of these tests. Eventually, if the pregnancy test is conclusively positive, you will continue to take progesterone supplements. If it is negative, you will stop the progesterone. It is recommended that you take 1 month off before resuming treatment. If the pregnancy test is positive, an ultrasound will be arranged for about 3 weeks later. This will confirm the location of the pregnancy in the uterus and determine whether it's a single or multiple pregnancy. A heartbeat should be seen at this point. Multiple pregnancy, for instance, twins, triplets, or quadruplets, is a potential risk of any fertility treatment. Multiple pregnancies carry a higher risk of premature delivery and miscarriage. Therefore, every attempt is made to avoid them. If your doctor discovers that you've produced many follicles, it may be necessary to cancel your cycle. Your doctor will discuss the situation with you if it arises, and other options will be explored. Other risks include ectopic pregnancy, where the fertilized egg implants outside the uterus, usually in the fallopian tube, and needs immediate medical attention, as it cannot develop normally there. In less than 2% of cases, ovarian hyperstimulation syndrome develops. In OHSS, the ovaries become enlarged, and extra fluid can accumulate in the abdomen, and there is a slight risk of developing blood clots. This complication requires rest, close monitoring, and may require hospitalization for intravenous fluids or the drainage of the abdominal cavity. As with all fertility treatments, the first time might not work. And if this doesn't work, your doctor might suggest stopping this method and trying a new one. This trial and error is a regular part of the assisted fertility process. It's important to expect it and keep a positive attitude in your work towards a successful pregnancy.